Today we are going to make antibiotics easier to remember by using one simple clinical framework. Instead of memorizing every drug separately, we will organize them by three things: their mechanism of action, their common clinical uses, and the major side effects you must not miss. The easiest way to start is to ask, what is the antibiotic targeting? Is it the bacterial cell wall, protein synthesis, DNA, or the folate pathway? Once you understand the target, the uses and side effects become much easier to recall. So first let us build the big framework. Cell wall drugs include penicillins, cephalosporins, and vancomycin. Protein synthesis inhibitors include macrolides, doxycycline, aminoglycosides, linezolid, and clindamycin. DNA targeting drugs include fluoroquinolones and metronidazole. And the major folate pathway drug to remember here is cotrimoxazole, also called TMPSMX. Think target first. It gives structure to your antibiotic learning. Now let us start with cell wall inhibitors, especially penicillins and cephalosporins. Their basic mechanism is inhibition of bacterial cell wall synthesis. Clinically, they are commonly used in infections like streptococcal throat infection, pneumonia, skin infections, urinary tract infections, and meningitis, depending on the exact drug and generation. The major risks to remember are allergy, rash, diarrhea, and most importantly, anaphylaxis. So before prescribing a beta-lactam antibiotic, always ask clearly about previous penicillin or cephalosporin allergy. Now moving to vancomycin. Vancomycin is also a cell wall inhibitor, but clinically we often think of it as a gram-positive rescue drug. It is especially important for MRSA and serious gram-positive infections. Oral vancomycin is used for C. difficile infection because it acts inside the gut. The two major adverse effects to remember are nephrotoxicity and vancomycin infusion reaction. So the clinical pearl is, infuse it slowly, monitor renal function, and in selected patients, monitor drug levels according to local protocols. Now let us move from the cell wall to protein synthesis, starting with the 50S inhibitors. The important 50S drugs in this reel are macrolides, clindamycin, and linezolid. Macrolides, like azithromycin, are useful for atypical pneumonia and upper respiratory infections, but remember QT prolongation and GI upset. Clindamycin is useful for anaerobes and dental infections, but the classic risk is C. difficile colitis. Linezolid is useful for MRSA and VRE, but remember thrombocytopenia and serotonin syndrome. So although these drugs share the 50S ribosomal target, their clinical associations are very different. Now let us talk about the 30S inhibitors, doxycycline and aminoglycosides. Doxycycline binds the 30S ribosome. It is useful in acne, rickettsial infections, and atypical pneumonia. Its major side effects are photosensitivity and tooth discoloration, so be careful in children and pregnancy. Aminoglycosides like gentamicin and amikacin are bactericidal 30S inhibitors and are used mainly for severe gram-negative infections. Their classic toxicities are nephrotoxicity and ototoxicity. A simple memory aid is amikid eyes and genta ears. Now we shift from protein synthesis to DNA-targeting antibiotics. Fluoroquinolones inhibit DNA gyrase and topoisomerase. They may be used in urinary tract infections, enteric fever, and selected gram-negative infections. But they should not be casual antibiotics. Important adverse effects include tendon injury, QT prolongation, and neuropathy. Metronidazole damages DNA in anaerobic organisms. It is very useful for anaerobic infections and amoebiasis. Its classic side effects are metallic taste and alcohol reaction. So remember, fluoroquinolones are useful, but they need careful selection. Now let us move to the folate pathway. Cotrimoxazole, or TMPSMX, blocks folate synthesis by acting on two steps of the folate pathway. Clinically, it is commonly remembered for urinary tract infection, pneumocystis jirovecii pneumonia, and nocardiosis. The major side effects are hyperkalemia, rash, SJS/TEN, and marrow suppression. So the pearl is very simple. Whenever you see cotrimoxazole, think potassium, rash, and marrow suppression. Now that we know the mechanisms, let us simplify the spectrum. For gram-positive organisms, remember penicillins, vancomycin, and linezolid. For gram-negative organisms, think of aminoglycosides, cephalosporins, and fluoroquinolones. For anaerobes, the key drugs are metronidazole and clindamycin. For atypical organisms, remember macrolides, doxycycline, and sometimes fluoroquinolones. This is not a full prescribing guide, but it helps you connect microbiology with clinical decision-making. Now let us look at the high-yield exam associations. For MRSA, think vancomycin and linezolid. For Pseudomonas, remember piperacillin tazobactam, cefepime, and meropenem. For atypical pneumonia, think macrolide or doxycycline. For anaerobes, think metronidazole or clindamycin. For enterococcus, remember ampicillin and vancomycin. And for ESBL organisms, the high-yield association is carbapenem. But be careful. These are pattern recognition associations, not permission for blind prescribing. Now let us focus on dangerous adverse effects, because in real practice and in exams, side effects often decide the safer antibiotic. Anaphylaxis is a major concern with penicillins and cephalosporins. Nephrotoxicity is important with vancomycin and aminoglycosides. Ototoxicity is classic for aminoglycosides. QT prolongation can occur with macrolides and fluoroquinolones. C. difficile colitis is strongly associated with clindamycin and broad-spectrum antibiotic exposure. And SJS/TEN is an important severe reaction to remember with cotrimoxazole. So never learn antibiotics only by coverage. Learn them by toxicity as well. Finally, let us end with antibiotic stewardship. Before prescribing, ask yourself 6 simple questions. Is it really bacterial? What is the likely source? Can I take cultures first? Can I use a narrower antibiotic? Can I de-escalate once results are available? And what is the shortest effective duration? This is the safest way to use antibiotics. The take-home message is simple. Antibiotics save lives, but only when used wisely. Right drug, right dose, right duration, and the right patient.